Actually, this time our speaker is very well known, Dr. Arvind Kulkarni from India. He will talk about the instrumentation techniques of C1-C2 joint. Yes, please, Dr. Kulkarni, we hear you.
Yeah, good evening, everybody. It's a matter of great prestige and privilege to make this presentation in front of all seniors and veterans of Middle East Spine Society. It was an honor to be at Istanbul in May this year. We had a wonderful meeting. So without wasting much time, I'll go straight to the topic. So anytime we think of what fixation in the craniovertebral region, especially C1, C2, it's always exciting. There is an adrenaline rush, not only when you operate in this area, but also when you talk about this area. And you know, this is a very big topic. You can keep talking about C1, C2 for hours together. So to limit it to just 30 minutes, I'm going to discuss about the relevant applied anatomy of C1, C2, the techniques of instrumentation at C1, C2, compare these techniques, and also to discuss about the salvage techniques if something fails. So I'll be speaking about the anatomy of C1 followed by anatomy of C2. Now these two vertebrae are totally unique to the entire spinal column. Most of the other vertebrae are typical. So these are atypical because they are challenged by different movements. It's mainly rotation of the neck as well as flexion and extension. So it is what is called a pivot joint. So there is the dents of C2 around which the C1 pivots, and since the head is placed on C1, so the head moves when C1 moves around C2. So because it has to give a constrained movement, so it is a very interesting kind of articular system that C1, C2 have. Now if we had the same discussion about 20-25 years back, we would speak more about the posterior arch, because most of the fixation techniques revolve around the posterior arch. Now I'm talking more about the lateral masses, because that is the gold standard procedure now, whether it is a trans-articular screw or whether it is a C1 lateral mass, C2 pars pedicle screw. So the lateral masses are thick, pieces of bone on each side. They have a cortical shell and a cancellous core, and since they support the entire occiput and the head and transmit a lot of load, as I said, the bone quality of C1 lateral mass is absolutely fantastic. So what are the applications of C1 lateral mass? Basically, when you put a trans-articular screw or a C1 lateral mass screw, you get a fantastic purchase in C1 lateral mass. So anterior to the C1 lateral mass is the C1 arch. What is the importance of C1 arch, anterior arch, is that when you are doing a trans-articular screw fixation, you are aiming at the C1 anterior arch. So in the next few slides, I'll show that this arch is divided into 4 zones, and the trajectory, the goal of this trans-articular screw, where it has to reach, it relates to the zones by which the C1 anterior arch is divided into different zones. Next comes the posterior arch. This is very, very relevant because of various reasons. One is that most techniques which were available prior to invention of this trans-articular screw fixation or C1, C2 fixation, segmental fixation, it was the posterior arch which was the anchor on which we put cables and wound it around the C2 posterior arch and fix the graft in between. So these are known by, this is basically called a midline fixation, and it is known by various names. We'll be discussing about that in the next few slides. So that is the importance of posterior arch. It is also important because the vertebral artery makes a groove on top of it. So when you do your dissection, when you do your exposure, it is very important to stay in the midline and not go beyond 8 to 10 millimeters laterally on the C1 posterior arch, otherwise you can injure the vertebral artery. Then comes the transverse foramen on both sides. This is important because when this is where the fourth portion of the vertebral artery is seen before it gets into the skull base and forms the before it winds around the vertebral artery groove or the posterior arc. So this is relevant because if your C1 lateral mass screw is lateral, you can injure the vertebral artery. So you should be very cautious when you're talking about the trajectory of C1 lateral mass screw. So this is the entry point of C1 lateral mass screw. We'll discuss these issues in the next few slides. So I'll go back. I'll also talk about this particular structure which connects the two halves of C1 arch behind the dents. So this is called the transverse ligament, and this is very relevant when it comes to decision making. So if there is a odontoid fracture along with a transverse ligament rupture, it is a contraindication for doing an odontoid screw fixation. Then you will have to do a C1-C2 fixation, and if this particular ligament is intact only, then you can do a osteosynthesis of odontoid fracture. So then comes the C2. Again, as I said, this is a unique structure. So it has a dents at the top anteriorly and two big lateral masses on both sides. The dents is significant because you can have a dense fracture. If you have a type 1 dense fracture which is totally at the apex, it can be ignored. If you have a fracture at the waist of the dents, that is the narrowest part of the dents, most of the time this needs surgery because it is usually unstable and prone for non-union. And then you come to the type 3, that is at the base of the odontoid of the dents, where it where it joins the body of C2. So these kind of fractures, because there is a large surface area, they tend to fuse. So these are usually conserved. So on either sides, what you see is this big articular surface, these flat surfaces. Basically, these articulate with the inferior aspect of the lateral masses of C1. So this is where the C1 makes its joint with C2. Now underneath this, as you see, this is a long column of bone going from the back to the front. Medially, it is at about 20 to 25 degrees, and superiorly it goes in an angle of 20 degrees. So this is the pedicle of C2. This is a very thick column of bone, and if you get a purchase here, the kind of fixation that you get is fantastic. So then comes this column of bone between the superior articular process of C2 and the inferior articular process of C2. This is the area which is called the pars interarticularis. So interarticularis is between two joint surfaces. Again, this is a thick column of bone. And what is the anatomic relevance of this? So if you can pass a screw from C2 into the C1 lateral mass, and that is through the pars. So this is called the TRANS-ARTICULAR screw. So you can also do a C1 lateral mass and C2 pars screw, but it is not as strong as a C1 lateral mass and a C2 pedicle screw. Then coming posteriorly, you see this thick, symmetric structure. This is the laminar in the spinous process. As we all know, when we expose the cervical spine, this is a thick stubby bone. This is the landmark to say that this is C2. So this has a lot of muscle attachments. So this is very thick. So in case you are not able to pass a C1 lateral mass screw, C2 pedicle screw or a pars screw, so you can always bank on the C2 spinous process and the lamina. You can pass a good long screw from one end to the other. So these are the anchor points wherein you can get purchase on C2. Now, this is where you see the transverse foramen of C2. So the vertebral artery, when it leaves the transverse foramen of C3, it makes a groove in the anterior part of C2 and then winds around this transverse foramen before it goes to the transverse foramen of C1. So this is where it makes that groove, that particular groove, and this is very relevant because if you're planning to do a C1-C2 trans-articular screw, then this particular groove has to be absolutely shallow. If the groove is deep, then it may be impossible to put a trans-articular screw, and this happens in about 20% of subjects. Now, what are the dimensions of the C2? So, you can put a screw which is about 22 millimeter in size, and you can put a screw which is close to 3.5 millimeter because the isthmus, where the narrowest part of the pedicle is close to 5 millimeters. So you can safely put a 3.5 mm screw across the pedicle of C2. So this is the relevant anatomy of C1 and C2. And like everywhere else, there is a traffic signal here in terms of red, blue and yellow. So this we should always be worried about. So the red is the vertebral artery. At every step, we should be conscious of the vertebral artery anatomy. So if it is a congenital anomaly for which you are treating, I would always advise everyone to do a CT angiogram and do a 3D, reformatted image of the CT scans, because you tend to get of the CT angio because you tend to get anomalies. You can have a lot of anomalies associated with vertebral artery, and inadvertently you can injure vertebral artery when you are instrumenting this area. So two things. So you should be conscious about the vertebral artery being lateral as well as superior when you are doing the C1-C2 screws, and you should also be concerned about the anomalies that vertebral artery can surprise you with during surgery. So always do pre-op CT angio if it is a congenital anomaly. Then comes these venous structures. We all know, when we do a C1-C2 fixation, these can, keep troubling and irritating you throughout the surgery. These are venous sinusoids. They are usually seen when, you come across this particular structure when you're putting your C1 lateral mass screw. So you have to be very, very patient, very, very diligent, very, very meticulous in controlling bleeding here. Use your bipolar, use your Surgicel, use gel foam, all kinds of assistance that is possible to get bleeding under control in this area. So one should be aware that you can bleed and should not be alarmed. If you're doing a C1-C2 for the first time, you shouldn't be scared because this venous structure can bleed and can trouble you during bleeding, and it is not very difficult to control it, though it needs patience. Then the structure that you come across is the C2 ganglion. So this can be of different sizes. So if the posterior arch is very thick and your C2 ganglion is also big, then it is impossible to do the C1 lateral mass. So some surgeons like Dr. Goel, etc., they advise you to cut the C2 ganglion to access the C1 lateral mass to put your screw. So sometimes you can be lucky if the C1 posterior arch is thin and if the C2 ganglion is small, and if it can be retracted inferiorly, you can put the C1 lateral mass screw without actually cutting this particular ganglion. So the C1-C2, being interesting. So C1-C2 instability is a very common situation that we see in clinical practice, and over a period of time, various techniques have evolved. As I said before, initially it wound around the posterior arch of C1 and the lamina of C2. So there are various kinds of midline fixations initially between 1930s and 1980s. In 1980s, Magriel and Seaman described trans-articular screw fixation, which was much efficient, much stronger fixation compared to the midline wiring techniques. This, generated a lot of interest in surgeons, and why not? Because this if the Gallies fusion would give you a 40 to 50% fusion rate, this trans-articular screw would give a fusion rate of to 100%. So in 1990s, Dr. Goel and Lahiri, so what they thought was, in certain situations you cannot pass a trans-articular screw, where it cannot, for example, when the C1-C2 instability cannot be reduced. So one of the prerequisite of a trans-articular screw is if the fixation, the instability has to be reduced. Only when it is reduced can you pass a C1-C2 trans-articular screw. So that is a challenge. So they came up with the idea, Goel and Lahiri, of getting individual purchase in C1 and C2 so that we can manipulate C1 and C2 and get reduction. So they came out with a technique which is a segmental fixation, wherein you put screws in C1 lateral mass, screw in C2 pedicle and then connect with the plate. So this was later modified by Harms and Melcher. So this was in 2001, almost about 10 years after Goel's description, that Harms and Melcher adapted this same technique with small variations in the entry point. But the only difference was they did not use a plate. They used the polyaxial screw head and a rod. So which we most commonly use when you're doing a thoracic and lumbar fixation. So that is possibly a bit more user friendly compared to the plate and screw technique of Dr. Goel. So these two kind of fixations, any of them give an excellent purchase. The fusion rate is close to 100%. So sometimes, one cannot pass a C2 pedicle or a par screw. So that is when this particular invention of Gorek and Wright, that is a C2 laminar screw, gets importance, because that is the only seat of purchase that one can take if you can't pass a screw in C2 pedicle or the pars. So that is a C2 laminar screw. So you pass screw from either side of C2 on the either side of C2 lamina. You can pass a screw angling medially on the opposite side as well as a bit superiorly, and this you can put a screw which is close to 20 millimeters. So this is a bailout. I usually don't use this particular entry point and trajectory. I usually don't put this particular screw unless I failed in putting a pedicle or a par screw. So it's more of a bailout mechanism. So these are the midline fixation techniques. So the principle here is to put a piece of bone graft between the C1 posterior arch and the C2
What happened?
I think they disconnected.
Connected.
Cüneyt Bey, kaydı durduralım, şimdi başlayınca tekrar başlarız.
Are there questions from the participants about what Arvind has told us till now? Abdul Hafiz is there, I think.
Mehmet is writing something. Mehmet Seçer.
Yeah. Yes, Mehmet says I use C1 lateral mass, C2 pars laminar pedicle, but what other options? Actually, there is, as Arvind has mentioned, there is C2 laminar fixation instead of pedicle or pars screwing. You can place your screw into the lamina from the contralateral midline. What does C2 3 facet screw? Oh, okay. I think it's not a good option, C2 to 3 facet option. Yeah, good question. Navigation, the role of navigation. I heard that there are some centers using that navigation things. I don't have that option, at least in my department. We are not using it. Onur, what do you think about the navigation?
If you have navigation, it's a good option. But if you don't have it, it's not a problem. You can do it. As Arvind has mentioned, you had to get a CT angiogram before the surgery. If you had the CT angiogram, it's possible to do it without navigation. But if you have it, it's a good option.
Yes. Actually, the most of the bleeding during the surgery for C1 lateral mass and C2 pedicle screwing is from the venous structures, not from the artery. Sometimes I see the artery, but it's almost not possible to injure it for C1 lateral mass screwing. But in cases of MEDIAL technique, the so-called C2, C1 TRANS-ARTICULAR screwing, the incidence of injuring to the vertebral artery is quite high. I used to do that in some cases before starting C1 lateral mass. I have 2 or 3 cases that I have punctured the vertebral artery. It may be controlled by bone wax, but it is recommended that you should not use that screw again. If you have punctured the artery, if you place a screw there, then it's quite dangerous to place a screw there. Salvage procedure is yes. Salvage procedure for C2 pedicle screwing is probably the C2 laminar screw. Arvind, did you come back? Not yet. Cüneyt Bey, do you know what happened with Arvind? Yeah, Abdulhafiz is telling, is it possible to do concomitant instrumentation through lateral cervical approach? Oh, any idea? I think there is no report I've seen in the literature for a lateral fixation, but you must turn the patient in prone and then place this instrumentation from backwards after a lateral approach, probably. Lateral approach is, I think, more difficult than posterior approach because you must see the artery, follow it, and then mobilize the artery. Without doing that, it's quite difficult. You did in 4 cases with lateral approach, Abdülhafiz. Oh, good. Good. And then you place your screws in which place? In which places?
And Kadir Kotil from Turkey has a technique from posterior, the odontoid screw fixation from posterior. He says that he has fixed a case from the posterior, then odontoid screw from posterior. Maybe it can be a combined surgery.
Okay, I don't have any experience with that. Using a part of the lateral occiput. Okay. So then you are doing a occipitocervical fixation, do you? Abdülhafiz is saying that with lateral approach is fixating from occiput to C2 body probably. Is it C2 body?
Ukarni.
Did you come back?
Hello, can you hear me?
Yeah, we hear you.
Can you hear me?
Yes, please share your video also.
Okay. Can you see the presentation?
Good.
Arvind,
can you see
share
the
your
presentation?
Click on it.
Yes, we can see it.
You can see the presentation?
Yes. Please click the...
Yeah, okay. So I'll restart.
Arvind, share your webcam.
Yeah, I'm trying to do that. It's not enabling.
Junaid,
That particular...
there is a problem that you switched my view to the top. There must come Arvind. Junaid. Where is Junaid?
Access.
Arvind, please share your image on the top. It must be green from the left to right. Look at the WhatsApp message.
Go to your pods. Pods click on.
Yeah, I'm doing that.
Share.
Huh?
वीडियो पे जा रहा है एक बार उसको क्लिक करके
Zilali,
Yes.
maybe we can go on without his image. We can hear him. He can go into the presentation without the webcam.
Now webcam is there, you can connect us.
Okay now?
Yes, we can see you. But Zilali is not here now.
Okay.
Okay.
Sorry?
Zilali is not here now. Yes, he is here.
Yeah.
Oh, he's there.
Okay. It's fine. Please continue. Thank you.
Yeah. So sorry for this interruption. Now, so historically started with posterior fixation. So a graft was placed between the C1 posterior arch and the C2 lamina. So it was in the form of a reverse M. So you can say W. So if you see here, most of them there is a notch here. So the bone graft is sculpted such that it looks like a M. You will see here. So this sat very well between the posterior arch of C1 and the C2 lamina, and we wound a cable around it. So it was basically initiated by Gallie, and so this particular fixation is good in preventing flexion extension. It gives stability in flexion extension. So the graft prevents extension and the cable prevents flexion. But so it was a good fixation, but it has a high pseudarthrosis rate, close to about 40 to 50%. It was not stable in flexion in rotation. So the main movement of C1, C2 is rotation. So rotation, in rotation it was unstable. So that's why it had a risk of pseudarthrosis, and because of which the wire used to pull out the configuration used to fail. And the other issue with this was, I'll show you in the next slides. So these, so after Gallie, then came this Brooks fusion, where they put bone graft on the two sides. So it was slightly better than the Gallie's fusion. So the blocks of bone placed between C1 and C2 posteriorly, and the cable was wound around it. So then it was again reinvented with a single sublaminar wire, so that you don't keep putting the wire and again and irritate the spinal cord. So in place of two sublaminar wires, it was supplanted with a single sublaminar wire. Again, it has risks of non-union, similar to the Gallie's fusion. And because you have to pass the wire through the C1 posterior arch and the C2 lamina, there is a risk of spinal cord injury in those situations where the canal is absolutely tight. So because of this, the surgeons were very concerned about these two issues. One is spinal cord injury because of the wire, implant failure as a result of pseudarthrosis. So that is when Magrill came with this landmark TRANS-ARTICULAR screw fixation. So here what we do is we pass a screw from C2 lateral mass into C1 lateral mass. So this is the trajectory. So it goes in an angular fashion, so from C2 into C1 through the joint of C1, C2 lateral mass. So this is called lateral mass fusion. So the advantage of this particular technique is it is very stable in rotation, but it is not very stable in flexion extension. So that's why surgeons advise a midline fixation along with the TRANS-ARTICULAR screw fixation. However, is much stronger than the cable techniques with the arthrodesis rate, fusion rate of close to 100%. So what is the entry point and what is the trajectory? So if you see in this diagram, the entry point is about 3 millimeter above the articular, above the joint, C2, C3 joint, facet joint, and about 2 millimeter lateral to the pars of C2. So this is the entry point, and the trajectory is such that it should cross the C1, C2 joint and get a solid purchase in C1 lateral mass. The screw that we use is usually a 3.5 mm self-cutting, cannulated, partially threaded cortical screw. The reason we use a partially threaded cortical screw is we want that lag effect. We want a distal part of the screw to be threaded so that when the screw is passed into C1 lateral mass, it pulls the C1 lateral mass towards C2 and gets a good purchase. Okay, so when it comes to positioning of the patient, it is very important to put the patient in a military tuck position, in a reverse Sandlenberg position, one is to reduce bleeding in the craniovertebral region when you expose. So because you're doing a reverse Hillenburg, so there is no much blood or pooling of the blood collected there. Second is you have to gently put the patient's neck in some amount of flexion. Otherwise, it's very difficult to get a trajectory. I understand that when you have to reduce C1, C2, it is in extension, but it is possible to place the patient in the best reduced position, but still in certain degree of flexion. Otherwise, it's very difficult to get that particular trajectory from superiorly posterior and anteriorly inferior, from C2 into C1. So that is the reason this particular technique is very difficult and contraindicated in patients who have a very lordotic neck, who have a very kyphotic thoracic spine. Patients usually with emphysematous chest, etc. Because the thoracic spine is too kyphotic, there is compensatory cervical lordosis, and in these situations it's very difficult to do a C1, C2 transarticular screw. So this is what I meant by the zones in C1. So when you're angling from C2 into C1, the C1 is divided into 4 zones. Zone 1 is superior to the C1 arch. Zone 2 is the superior aspect of the C1 anterior arch. Zone 3 is the inferior aspect of the C1 anterior arch. And 4 is below the C1 anterior arch. So zone 3 and zone 4, if you try to pass your screw angling in this particular direction, mostly the screw will be anterior to the lateral mass of C1. So it is very important that you aim at the first zone 1 or the zone 2 when you're passing this particular transarticular screw. So the screw, the trajectory of the screw is medial about 5 to 15 degrees, and in the lateral view, there is no fixed angulation, but it should be such that it should cross C2 pars and land into C1 lateral mass, angling in zone 1 or zone 2 of the C1 anterior arch. As I said earlier, there is a high riding vertebral artery in 20% of subjects. So in this particular situation, it becomes a bit tricky. So this particular groove, so this particular specimen here, both of them, the one on the left as well as the on the right, they have very thick, pars. So it is very easy to parse a screw from inferior to superior. But if there is a big groove here of vertebral artery, it is almost impossible to pass a screw into C1 lateral mass without injuring the vertebral artery. So in such a situation, the trajectory of the screw should be such that it should just skirt to the posterior cortex of, it should just skirt through the posterior cortex of the isthmus of the pars and into the C1 without transgressing this particular groove here for the vertebral artery. So I was just hearing about navigation. These are the situations in which navigation plays a role so that your trajectory is avoids that particular groove. Because when you are doing your surgery, it is C-arm guided. If you're not using navigation, it is usually C-arm guided, and there is a high chance that you may not be able to appreciate this particular groove. But if you are using navigation, you get CT cuts, sagittal cuts. So when you use navigation, it is possible to avoid the groove as well as to be in that particular narrow isthmic part of the pars without injuring the vertebral artery and be safe. So that is why some surgeons have come out with anterior approach. So, anterior approach, the advantages are we are familiar with anterior approach, and patient C1, C2 gets reduced in extension. So when the patient is positioned, the C1, C2 is already reduced. Because anterior approaches are associated with low rates of infection, the infection rate through this particular approach is less. These are all the advantages of a C1, C2 anterior approach as advocated by the proponents of anterior approach. So here the entry point is on the medial 1/3 of the C1-C2 articulation of the lateral mass, and the trajectory is about 20 degrees laterally in the coronal plane and about 30 degrees posteriorly in the sagittal plane. So when the patient is positioned, the C1-C2 is already reduced because it is an extension, and when you choose this particular entry point, so it goes 20 degrees coronally laterally and 30 degrees posteriorly in the sagittal plane, and again you put a 3.5 mm cannulated cortical screw so that you get a similar purchase in C1 lateral mass. I don't have any personal experience with anterior approach. I would love to share your experience with this particular approach. So as I said, why should we go anterior? So it is a familiar approach. It is in those situations where the groove for vertebral artery is too big, and if it is not possible to pass a screw in the pars posteriorly to get through a transarticular screw, maybe you go anterior. However, it is not a very familiar approach. I don't use it. So I would, as I said, love to share your experience with this particular technique. So now we come to the relatively newer technique, that is C1 lateral mass and C2 pedicle screw. So as I said, the C1 lateral mass is a very thick structure. It is a dense piece of bone, and the purchase here that you get is phenomenal. So the entry point here is at the junction of the posterior arch and the C1 lateral mass, exactly at the center. So as I said, so it's a thick shell of bone, and there is fantastic. So even in sagittal dimensions, the superior inferior dimensions, it's about 4 to 5 millimeter, and in anterior posterior it is about 13 to 14 millimeter. In the mediolateral it is about 4 to 5 millimeter. So you can easily put a 3.5 to 4 mm screw easily into this particular lateral mass. So the trajectory is usually about 10 to 15 degrees medially. You should be very careful because the anatomical structures such as hypoglossal nerve as well as the internal carotid artery are just anterior to this. Though you need to be bicortical to get the best purchase, you should be always aware that you should not go beyond the anterior cortex too much, otherwise you will injure these particular structures. Again, it is hard to put this particular screw. So if the posterior cortex is too thick and if it is coming in the way of your screw insertion, what I do is I usually drill a semicircular part of it on both sides. So once you drill this part, the posterior aspect of the C1 lateral mass can be seen, because if you have a thick, big posterior cortex, posterior arch, as well as the C2 ganglion here, as I said earlier, it is very difficult to get the entry point of C1 lateral mass. So I would burr this particular portion to put a screw. Some surgeons such as Dr. Abumi, they advocate passing screw through the pedicle of C1. So the entry point here is actually on the posterior arch. So it is just beneath the vertebral artery groove on the C1 posterior arch, exactly in the center, exactly at the same area where it joins the C1 lateral mass. Again, one should be careful here because one can injure the vertebral artery. And you should do a CT study prior to putting this particular screw, because a large percentage of patients have a 4 mm thickness of posterior arch at the vertebral artery groove, and some people, a certain percentage of patients, they have very thin groove here. So it is very easy to injure the vertebral artery when you are passing this particular screw, and the trajectory is the same. So this is a case where a screw was passed through the pedicle of the C1 lateral mass through the posterior arch. If you see here. Coming to C2 pedicle screw. So the C2 par screw is a screw which goes between the two articular surfaces through the pars. The pedicle is from posterior lateral to anterior medial. It is at an angle of about 20 to 25 degrees medially. Again, you need to do a study of the pre-op images, or if you are using navigation, that will take you where you need to go. So you divide the pars into 4 areas: superior-medial, superior-lateral, inferior-medial and inferior-lateral, into 4 quadrants. And the entry point for the C2 pedicle will be the upper medial quadrant, angling about 20 to 25 degrees. Actually, to put this screw is to put a pen field. So, detach the outline to axial membrane, feel the medial aspect of the pedicle using a pen field, and you drill in such a direction so that you are angling at the anterior aspect of the C2, and that is your trajectory. So it usually takes a screw about 20 to 24 millimeter in length and 3.5 millimeter in diameter. So this is how it goes. So superiorly towards the anterior aspect of C2 and medially about 20 degrees. So this is one of our cases where we are already passed. It's usually put the C1 lateral mass screws first and then the C2. So this is how it goes superiorly and medially. So this is a case where we put a C1 lateral mass screw after burying the C1 posterior arch. You can see this going in, and bicortical put this C2 pedicle screw. So the entry points of Goel and Harms are: goal is to put C1 lateral mass screw, pedicle screw. So if you're not able to, if you're not confident of putting a C2 pedicle screw, you can put a partial par screw. So the same trans-articular screw which goes all the way into the C1 lateral mass, only it goes just midway. It just stops short of the articular surface of C2. This is about 18 to 20 millimeter in size. So this is not as strong as C1 lateral mass C2 pedicle screw configuration, but it is satisfactory. So this is a case example of a C1 lateral mass and C2 par screw. You see here. So if the screw at C2 were more medial, then you could say it is a pedicle screw. So this is a C2 par screw and the C1 lateral mass screw. I did this very recently, and as you see, I use navigation in this particular case. So a patient is placed in a reverse Rendlener position with neck in extension with traction, and this is how the screws were put. So this is if you see, this is a partially threaded cannulated screw, because the C2 ganglion was left intact. The smooth part of the screw doesn't irritate the C2 ganglion. That is why we use a partially threaded screw. It is only threaded at the tip. So then comes the C2 laminar screw. So this goes from one side, ipsilateral side, to the contralateral side. So you insert one screw from each side, and this can be connected to the C1 lateral mass screw. So it was described by Gorek and Wright almost at the same time. So this is more of a bailout mechanism. So this is how. So one screw is cranial, the other screw is caudal. You can see the thickness of this particular lamina is about 4 to 5 millimeters. And here at the entry side, at the point of entry, it is much more thicker. So it is very easy to pass a screw from one end to the other without harming the spinal cord. So this is a case where we use this particular technique. As I said, I use it only when there is when I need to bail out a particular case. So here there was a screw placed, cage C1, C2, but the cages burst into the lateral mass of C2 and also destroyed the pedicle. So when I had to revise this particular case, I removed the cage, I changed the C1 lateral mass screw, I put a bigger, longer screw, and here if you see, I put a laminar screw from both sides. So this, as I said, is more of a bailout mechanism. And what are the other applications of this particular screw? So this particular C1, C2 technique. So this patient had a C1, C2 instability as well as a long-standing myelopathy. So the same thing can be extended lower down. So this is not possible if you are putting a trans-articular screw, unless you put a screw with a, with a tulip and then extend it. I don't know how stable it is. So this is because it is a segmental fixation. It can be extended down, or it can be a part of occipito-cervical fixation also. So this is a case again. Trans-articular screw cannot be done. You cannot pass a trans-articular screw unless you have a reduction in place. But the advantage of C1, C2 segmental fixation is such that you can reduce it on table. So this particular patient, a young girl about 20 years old, you can see the C1, C2 is not reducing, instability is not reducing in extension. It is the same in flexion as well as in extension. And it is not reduced even after positioning under anesthesia with traction and in extension. So what I did was I put a C2 pedicle screw first, then C1 lateral mass screw, and I could actually pull the C1 lateral mass posteriorly and fix it. So I got a fantastic intraoperative reduction using this particular technique. So that is the advantage of segmental fixation. In terms of strength, if you see here, C1 lateral mass C2 pedicle screw gets a plus in axial rotation, flexion extension as well as in lateral bending. Same with C1 C2 trans-articular screw. But as I said, laminar screw is not as strong, but it is better than a C1 lateral mass and a par screw. So the best technique is C1 lateral mass and C2 pedicle screw, followed by C1 C2 trans-articular screw, followed by everything fails. The bailout is going to the Himalayas, that is to the occiput. Now coming to odontoid screw fixation. So this is usually in type 2 and high type 3 odontoid fractures. It is an alternative to C1, C2 fusion. It's usually, especially in type 2 fractures, they tend to go into non-union, or those patients where, if it is type 3 and the patient doesn't want a halo and needs to be mobilized fast. So that is where we do it. Contraindications is, if you're not able to reduce the fracture on table, so then you have to do a C1, C2 fixation. If there is a transverse ligament injury, then we need to do a C1, C2 fixation. If there is a non-union, if it is an old C1, C2, if it is an old odontoid fracture, you cannot do osteosynthesis, then you need to fuse the C1, C2 joint. And if the fractures usually don't come in typical type 1, type 2, type 3 variety. They come in various shapes and sizes, various permutation combinations. The type 3 fracture can sometimes go through the facet joint of C1, C2. In such a situation, you can't do a C1 odontoid fixation. You need to do a fusion, C1, C2 fusion. So this is basically a motion preservation surgery. So the isthmus of the odontoid should be at least 9 mm in diameter to pass a 3.5 mm screw, 2 screws. If it is less than 3.5 mm, you can pass only screw. So we did a study, I authored this particular study wherein we studied the dimensions of the odontoid of patients of Indian population. And we found that in 55% of these subjects, one cannot pass 2 screws because the waist of the odontoid is very narrow. So in such a situation, we usually, most of the times what I do is I pass just a single screw. I would love to hear from you whether you put 2 screws or 1 screw. So the screw should be such that it should go through the fracture from inferior anterior to posterior superior. So this is possible only if the fracture is either transverse or oblique in the opposite way. The fracture should start superiorly, anteriorly, and go inferiorly, posteriorly. It should be oblique fracture from front to back. That is when we can pass this particular screw. It should not only cross the fracture area, but it should also get a purchase in the distal cortex. If you should get a good bite in the distal cortex, only then you can expect a union here. Otherwise, the screw can migrate inferiorly. So you usually need 2 C-arms because you need to pass the screw. You can't keep changing the C-arm from AP lateral, you will lose patience here. So when you're passing this particular screw, you should be able to see the AP as well as lateral at the same time, because the screw has to be banged in the center. It is like hitting the bullseye. You cannot make any mistakes here. So in the AP as well as in the lateral, you should be in the center. So this is the kind of purchase one should get. So if you see here, the tip of the screw has taken purchase in the distal cortex and it's absolutely in the center. This was one of my first cases. So these are techniques where, odontoid fracture is either oblique in a different direction or a situation where there is a transverse ligament fracture or there is non-union. That is when you do C1-C2 Goel harms or a Magrel's fixation. So you do either of them if there are contraindications to osteosynthesis of odontoid fracture. So this is a fracture which was done about 3 years back. If you see here, it is a C2 fracture in a configuration where there is a C2-C3 congenital fusion. So here is generally the screw which we use here is a 3.5 or a 4 mm cannulated, cancellous, partially threaded screw, so that it gets purchased only in the distal fragment and pulls the distal fragment towards the proximal fragment. So and usually the length of this screw is about 35 to 45 millimeter. But in this particular case, we used a 50 millimeter screw because there was a congenital fusion of C2 and C3 and we had to put a very long screw to get a distal purchase. So this ultimately fused. Thank you.
Thank you so
Thank
much.
you, Arvind. It was great talk, really. Although we had some lack of in between. Oh, it's very nice that Atul Goel has come to the webinar. Welcome, Atul. How are you? There were some questions from the audience. Do we have any experience about the lateral approach and fixation?
Lateral approach.
Lateral approach. Lateral upper cervical approach and fixation.
I have no idea of this approach. Maybe the neurosurgeons, you tend to go laterally for your to exercise your tumors, etc. I think some people do a lateral release in fixed C1-C2 dislocation, just to release the joint.
Another question: in which cases do you use 3-point fixation or traction?
We use traction in all cases.
Traction. We have seen in the cases you have shown us, there were a cranial traction. Am I right?
Yeah. So that was to keep the C1-C2 dislocation reduced. So you have to keep it stabilized in extension. So in extension, the dislocations reduce. So to keep it stabilized in that particular position, you put the patient in traction.
Yeah, but you can do the same with a Mayfield 3-point head fixation.
Yes, yes, of course.
Do you use it any time in any cases?
No. When I was working with neurosurgeons, we used to use this Mayfield, but I usually tend to use this Gardnerville tongs.
Okay. Okay. Another question is coming probably, but Onur, do you have any questions?
Yes. Can you please tell us in the technique of C1 lateral mass and C2 part screw, you told us you're using partial cannulated screws. Can you tell us again the reason?
When you're using the C1 lateral mass screw?
No, in the technique in the C1, okay.
So when you
sorry.
So when you put the C1 lateral, so when we insert the C1 lateral mass screw, the proximal portion is overlying the C2 ganglion.
Yes.
So you don't want the threaded portion to irritate the C2 ganglion. So that is why it's partially threaded.
Okay. And what's the property of the Herbert screws that you're using?
Yes.
In the odontoid.
No, I don't have any experience with that. I don't have any experience with that.
You told us that you're using Herbert screws in the odontoid fractures.
No. That is literature, not me.
Okay.
Yeah, that is literature. I usually tend to use one partially threaded cancellous screw. Either it ranges from 35 millimeter to about 50 millimeter in length.
Arvind, it was really a great presentation. Thank you so much.
Thanks.
Okay. Dr. Emre is writing a question, and I want to ask about the complications of odontoid screw fixation. I've seen in the literature many complications, like the screw just in front of the screw, the bone may have broken.
Yeah.
The screw may have broken in case of non-union, and the tip of the screw may go too deep, and then can injure the basilar artery or the pons in the up. Did you see any complication for odontoid screwing?
Yeah. So I have done about 9 cases of odontoid fixation. Nine cases. Though I have not had, fortunately, I have not had any bad complications. I have had one pseudarthrosis, one non-union, for which we went back and did a C1-C2 fixation. So this patient, along with odontoid fracture, he had injured his eye. So, and for the eye problem, the patient was on long-term steroids. So because of long-term steroid intake, probably the odontoid did not unite, fracture. So we had to do a C1-C2 fusion. But you see, if you are using navigation, sometimes, you know, the distal fragment, it is a virtual image that you are using. Sometimes when you're using a virtual image and when you're putting your guide wire and your screw, sometimes you can push the distal fragment into the base of the brain. That has happened with the surgeon, because it is not a real image, it is a virtual image. So the surgeon was putting his screw and he kept putting it again, you know, it was not stopping at all. And on the navigation, he was seeing that the screw is biting the distal fragment, but he was not getting the feel. So when he took a C-arm image, the screw was in the brain.
Okay. One question is coming from
navigation.
Okay. One question is coming from Dr. Emre. What kind of technique do Dr. Yaman and me are using in odontoid fractures? I can answer this. Actually, I don't prefer the anterior dislocation cases for odontoid screwing. Instead, I prefer posterior dislocations. And we must be very careful not to choose a case with a transverse ligament rupture. This is all. Actually, in very old patients, we can try a posterior fixation instead of odontoid screwing. What do you think, Onur?
And if I have to use, if I did the indications for odontoid screw, I prefer odontoid screw, and I use acute rack screws. It has self-treated. It can pull up the tips of the odontoid down. And now we're trying to design a new screw that has also, let's say, teeth that can hold also the top of the bottom of the C2, so that they can also put it down and bring these two fracture parts together. And if I have to use posterior technique, I use C1-C2 TRANS-ARTICULAR technique.
Okay. Arvin, one question is about infection. Did you see any infections on fixation in this region?
No, not at all.
Okay.
Generally, this area is quite clean.
Yeah, it is. And one advantage of the region is that lymphatic drainage is very strong. Then
Okay.
the infections of the region is quite rare.
And do you have any experience with the anterior fixation C1-C2?
No.
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 But
I don't have.
you showed us the biomechanical analysis of the lots of techniques. There was a technique acceptor, C1-C2 TRANS-ARTICULAR technique, and this is I think we can see the biomechanics of C1-C2 TRANS-ARTICULAR and also C2 posterior TRANS-ARTICULAR. I think there is no study about it.
Yeah. One more question. Do you have any experience with the C1 laminar screw?
No, so that is one more. Yeah, that is one more described technique. So you can actually pass a contralateral screw in C1 arch, posterior arch. It was described by someone from China.
Okay.
So I don't know. I don't have any personal experience.
But it's a very thin lamina. Then it may not be easy to apply a laminar screw in all cases.
The thickness is about 4 to 5 millimeter. The posterior cortex in the anterior posterior plane. But I don't think it is possible to pass a screw.
Okay. One question from Dr. Kasmani is that how often do you need an anterior release if you cannot reduce after positioning? If it is not reduced, anterior release, is it possible?
Yeah, I have never done an anterior release. But you know, if you do a posterior release of the C1-C2 joint and do manipulation with the screws and you know some amount of positioning, one can get a very good reduction, as I showed in one of the cases.
Yeah. Okay. I think there is no more questions. We thank you a lot for very nice lecture and very good discussion. I think we can close the session.
Arvind, thank you so much.
Thank you very much.
Thank you a lot.
I look forward to meet you in Delhi, New Delhi in April.
Yes. Hope to see you. Goodbye.
Arvind, thank you so much.
You're welcome. Good night. Thank you very much.
Thank you. Thank you. Thank you.